Hey everyone, and here is your video lecture on cardiovascular endurance tests. Again, you would have covered some of this, or will cover more of this in detail in your labs, but we'll look at it with a slightly new lens and provide a bit more information around these tests for you. When we're looking at cardiovascular tests, we're looking to see what sort of endurance people have. And so we're really talking about aerobic respiration. And of course, when we're talking about aerobic respiration, we're talking about how much oxygen our mitochondria can utilize during prolonged aerobic exercise. And so when we're looking for this maximal amount, so the most oxygen or volume of oxygen that our bodies can handle as a capacity rate, we're really looking at our VO2 max. So the maximum amount of oxygen in milliliters per kilogram per minute. And so we have a rate with that because it's by some unit of time. Right? And with that, what we end up getting is this indication of our endurance or aerobic capacities, and we can also look at a little bit of our health status. So if we were to consider a cardiovascular system, and if it was operating at maximum capacity, when we're thinking about our aerobic capacity, because that's really an indication of our cardiovascular system, they're tied to one another, right? Or the way of our heart and blood and lungs all work together is an indication of aerobic fitness, but also our aerobic health and our cardiovascular health in turn because of that. And so what we'll find is with that indication from our cardiovascular health, we can also get a pretty good prediction at times from that as far as our mortality rate or our likelihood or relative risk of death. And ultimately, if we have an increased likelihood of cardiovascular disease, so heart disease, maybe like atherosclerosis, so narrowing of the arteries, in particular the arteries of the heart. Those are kind of the main cardiovascular issues that we can come across that our cardiovascular functioning will decrease because of those and will therefore also have a higher chance of death. So what we'll absolutely, as a bare minimum, need is a VO2 max, so the maximum amount of oxygen we can process for aerobic respiration or cellular respiration is 13 milliliters per kilogram per minute. Again, that's a rate, right? So other measures that we can use to have some indication of cardiovascular endurance are things like our heart rate. We'll discuss how that's correlated to cardiovascular endurance, our blood pressure. We can use ECGs or electrocardiographs to look at our heart nerve conduction system, and we spoke about that in our cardiovascular section. We can look at O2 consumption as well at submaximal workloads, and we're going to investigate that a little bit more. And we do that, our submax workloads, to try to predict our VO2 max through graded exercise tests. So we have these slowly, incrementally increasing workloads for exercise that we do, and through the correlation between that consumption of oxygen at those submax workloads, we can make a prediction of what our VO2 max is. And there's a few reasons why, which we'll explore a bit later. Here we'll see our treadmill protocol tests, or we'll start with the treadmill. But there are a number of different ones, for example, bike or row ergometer. You can also have this pool, essentially. It's like the slightly higher than one or longer than one person's height, so it'll be roughly about 2 people tall, and it just runs water through it, and you kind of have to swim against the current, and you stay roughly in the middle, and so it's kind of like a swimming treadmill. So there are different protocols that we can do. If you remember from the metabolic cart, we can measure directly our volume of oxygen as well as our respiratory exchange ratio, so the amount of carbon dioxide relative to the amount of oxygen being respirated. And of course, we'll see that flows in through a one-way valve and then gets exhaled into the metabolic cart that way. So that's one method. And these protocols on treadmills or any of these devices can either be continuous or discontinuous. Continuous just means it starts and continues on until the end. Discontinuous has little breaks as you go along and has measurements throughout. Typically for cardiovascular based tests, they are generally continuous because we want to see how the body responds to continuously increasing workload. Okay, so again, as we take a look here at our treadmill protocols, we do want to slowly and with precision increase the workload. And we can do that through a couple of different means. If we're thinking about treadmills specifically, we can increase their velocity, so the rate at which the belt is moving and therefore you are moving, or the grade or percentage incline that the treadmill is at. You can utilize both as well, but again, having a predetermined amount for how much those go up will give you a corresponding response through your VO2 max. So we can have a graded running test. We can have a running test at 0. So graded just means with incline. You can also have walking tests as a way of trying to assess your VO2 max. However, again, this is going from a, say, VO2 max test where you actually go right up to your VO2. There are different ones where it would be perhaps a challenge, maybe submax though as well at 0% gradient. And then last but not least, we have a walking test, which we typically will correlate to what your VO2 max is through knowing the workload and the increase in either respiration or your heart rate and or both. Okay, so we'll take a look at a couple specific protocols. The bulky and the Bruce protocol. Both have their advantages and disadvantages. The nice thing about the bulk test is that it has an initial low workload and a gradual increase. The Bruce protocol jumps up a little bit more stepwise, but with that speed and gradient change every 3 minutes, what will tend to happen is we know one thing is that steady state is hit, typically within 3 minutes. So as we increase that workload a little bit, your heart rate and physiological systems can hit a plateau or a steady state within that amount of time before you increase again. So we can ensure that that the readings that we see between your increased workload and say increased heart rate are due to that steady state being reached rather than exponentially getting away from you. If you're to increase every minute, your body doesn't necessarily have enough time for the cardiovascular system to catch up to the workload. Therefore, you get a little lag. So you might increase the step at which you're performing above and beyond your beyond what your cardiovascular system can handle at that time. Okay, we'll take a look again when we get there. So if we look at the bulk treadmill protocol test, we can see here both gradient time allotment continues to increase, and our speed stays fixed. So with that fixed speed, again, as the gradient increases, it becomes more and more challenging. We go up all the way up to 14%. And here we have females or women running at these gradients as well, but at a slower speed, so 7 miles per hour, versus the 8.5, okay? If we look at the Bruce protocol, and in lab, you would have seen a submax Bruce protocol, so we're below our actual threshold. But if you wanted to, you could continue on past the first few stages to the final point. I believe another protocol actually even has it potentially going longer than this. So you essentially go until you cannot run anymore. 22% gradient. Yeah, so that would be your final stage that you could get to. Very cardiovascularly fit if you're able to run at 22% gradient at 6 miles per hour for 3 minutes. Very impressive. But as you know, we can find a relationship for how what your maximum is by finding a correlation and plotting a linear graph between your heart rate and your workload, which will then give us our prediction of your VO2 max from a sub-maximal effort, which is good because not everyone can push themselves long enough to get into these stages, or they do not have enough mental training to get to those points of discomfort either. Okay, that's just a duplicate for some reason. Okay, so take a look now at our cycle ergometers or stationary bikes. I think an important thing to note at this point in time is that when we're looking at whether to pick running or cycling or rowing or swimming as our means to assess VO2, there's a lot of considerations. Obviously, one is equipment, but two is also being sport specific. And one of the reasons that I bring that up is, as an example between running and cycling, is we'll find people's VO2 max is typically 5 to 25% lower on bikes versus running. And one of the reasons is essentially you're sitting down while cycling versus running and you're standing and supporting your own body weight for that. So that's one of the potential downsides that you could find. You know, it's a bit of a skill and a technique to be able to maximally work on a spin bike or a stationary bike, but there are advantages. So again, speaking to the sport specificness of it, cyclists and triathletes for their cycling portion will definitely, for their VO2 for cycling, use a cycle ergometer versus a treadmill to figure out what their VO2 is exactly for that specific event, and it allows them to track along in their fitness and or improvements in that. It's good for individuals who, might, it says postural instability and arthritis, which is true. So issues with joints and weight-bearing activity, like running. So it's still a way that we can assess that in a non-weight-bearing activity. It's easier to monitor things like blood pressure. ECG artifacts are less because the electrodes and wires aren't moving as much if you're trying to do some heart measurements. And it's easy to make small incremental workloads. But back to the point of, the blood pressure and artifacts is you can also do something called a blood lactate test a lot easier because, again, there's not quite as much upper body movement as there is with running, so you can be a bit more continuous with that. Okay. When we have non-athletes on here, what we'll typically do is we have a pedaling rate. This is for the workload at about 50 to 60 revolutions per minute, or RPM. And the workload is increased about 25 watts, so that W is watts, every 2 to 3 minutes. And again, just allowing our bodies to hit steady state before we increase again. 25 watts for most individuals is pretty reasonable. As far as the amount of work that increases. And if we think of our work rate in watts on a bike for a moment, when we're talking about watts, we're talking about power. So it's how much force over time. So if you think back to when we were talking about our strength, and that's a continuous thing. So usually you can look at statistics on a power meter from a bike that will demonstrate instantaneous, every 3 seconds, every 10 seconds. And usually you want to use about every 3 seconds because instantaneous can be quite jumpy, especially for beginners because there's not a smooth continuous pedal stroke. So you use typically about a 3-second average for that. And it's enough to get the moment-to-moment changes, but not too much, not the same amount of lag as a 10-second would show you. So here we are if we have our untrained or trained individuals, and the amount of watts we'd want them to change. This is kilopound meters, which is just a different way of measuring the same thing as watts, but I think watts generally would be a more common unit of measurement for cycling. And here we are, 2, 4, 6. So every 2-minute increments, we go up 50 watts here, and untrained. It's a bit of a jump, but reasonable. And then 50 watts, you just start lower for our untrained individuals. Okay. Moving forward now. So if we look, I'll back up a little bit. So there's a common question where individuals, once you get your VO2 or you're predicting it, or we start talking about VO2 max, we already know the lower end. We spoke about that before. It was roughly 12, 13 milliliters per kilogram per minute. But we also like to know what the top end of human physiology is. And typically what we find for like the most cardiovascularly endurance fit athletes in the world, they come from sports like cross-country skiing, sometimes rowing, and marathon running. So again, these two weight-bearing activities usually demand the largest amount of muscles moving for the longest period of time at the highest intensity. Therefore, we find the highest VO2 maxes in the world. And sure enough, we find that this value is somewhere between 75 for elite marathon runners, 85 for cross-country skiers, and at the very, very top end, these are like truly exceptionally outliers, would be around 96 milliliters per kilogram per minute. So just to digest what you have just seen as far as numbers here, and again, if you look back to any of the calculations you've done for lab with the ACSM equations to try to get some point of reference as well, we're saying that these individuals are essentially 10 times more capable than the lowest number of VO2 that you need to sustain life. And again, this is a rate while they're working. So we see that, almost, let's just round up to 100. So, and that's 1, 2, 3. So that's 0.1 of a liter per kilogram per minute. And again, that number can add up very quickly if you're going for, let's say, 2 hours, like the fastest marathon runners are, 2:15, depending on the course. Okay. And just to note, here's kind of a percentile rating of men and women at different age categories. Again, this heading can be carried over here. And if, lo and behold, we look at the very top end of men, in the youngest category, we see that their VO2 max is greatest. 60 to 69-year-olds, it is the lowest, even at the top end there, just looking at the 95th percentile. We look at women at that same category. We see that on average, for aerobic power, again, this is what we're talking about, we see that it's 56 versus 66 for women, and at the bottom end, again, a little bit lower for women in that range. And that's not to say that women, for example, at this age category can't get their values a little bit higher. They just sit in a slightly different quartile at the top there. Okay. Sorry. Maybe I'll speak to like the age component of this too, just briefly before I move on. So with age, over time, our VO2 capacity does decrease. There's a number of different reasons for this. One being our lungs typically become less permeable. You pick up environmental things. Things like illness can leave some scar tissue within the lungs potentially over the years. Things accumulate, and therefore there's less capacity for gas exchange, as well as just a general slowing of max heart rate, and that decreases over time as well. And so we would expect that with our cardiac output decreasing over time, which you of course know, as well as our lungs becoming less permeable, we would naturally expect that our maximum amount of volume that our bodies can handle will decrease with time. Okay. So heart rate measures, why do we use this? I thought we were talking about volume of oxygen. I thought oxygen was really important for our aerobic capacity. Why are we looking at heart rates? Well, of course, it's because we can measure heart rate in a non-invasive, convenient, and efficient manner, much more readily so than hauling out that whole metabolic cart, Hans Rudolph mouthpiece, the whole expensive piece of equipment to try to get someone's VO2 and respiratory exchange ratios. We can essentially just use a heart rate strap. Now, I have spoken about this in lab. I will speak to it again. The heart rate that you get typically from watches, once you get exercising, by and large, is quite inaccurate. It is not a great representation most of the time for most people. And this is both anecdotally and when you actually look at some outside of these products research. Okay, so again, the best way to go is getting a heart rate strap. Even though the watches are getting better, the more lights you have, so like in colored of lights, because that's how it measures your heart rate. The watches will shine a light through your skin, and based off of the changes in absorbency of the light, so as your blood pumps through, it will try to see how much of that is absorbed or not, and it will take certain readings of, okay, lots of light was absorbed there, less there, and therefore that equates to one heart rate or one heartbeat. Again, the technology behind this is getting better all the time, but nothing, it still hasn't met the same standard, I would say, as a heart rate strap in responsiveness to changes in heart rate or in long-term accuracy over a bout of exercise. Day-to-day, walking around, daily activities, it's great. Okay, that was so far from what I've seen of the research on that, but just as a side note. So getting back to why we use heart rate as a measurement, well, we know, of course, from a physiological perspective that our heart rate is a great indicator because of our heart, of our cardiovascular system. It is the mechanical pump for that. So what we tend to find is as our fitness and accordingly our health increases over time, we'll see a decrease in heart rate, and that is resting heart rate. So when we're exercising, it's not our peak maximum heart rate that we can get to. For some individuals, that'll actually increase if you're going from an untrained to a trained individual. But ultimately, if you are increasing in your fitness, the same amount of work, once you become trained, you'll find a lower heart rate for that same workload. So that's an indication of fitness. So if you put yourself on a spin bike and you are pedaling at 200 watts for 20 minutes, and normally you do that and your heart rate is 165, after 6 to 8 weeks of training, you're doing your 200 watts for 20 minutes and you notice your heart rate is now 160, 155. That's an indication of an improvement of fitness. Okay. We also know heart rate has a linear relationship with VO2. So, going back to our treadmill protocols and what I was mentioning earlier, what you've done in your aerobic lab, all of this should ring true, where when we see that our heart rate is allowed to linearly reach steady state as our workload steadily increases incrementally, we will find that our VO2, if actually measured by a metabolic cart, is also linear for a certain period of time along with that heart rate. But again, a few things have to be true for that. And that's our workload is linear, that mechanical output becomes linear, and our exercise increase because of the workload, the intensity increases accordingly. So here, to just speak to this for a moment. So I mentioned that as we get more fit, we have a lower heart rate while resting, right? So while we're exercising, it'll decrease for the same workload. But if we consider rest our lowest workload that we'll ever do day to day, we can find that our resting heart rates get quite low. So endurance athletes, even as hobby athletes, most will see their resting heart rate between 35 to 56. You know, your average weekend warrior, cyclist, runner, etc., you'll see probably closer to 50, 55, depending on who they are. Professional elite endurance athletes, they'll get quite low, down to about 35. And at that point in time, you sometimes, depending on who you are, you almost have to, you don't have to be concerned, but you definitely need to watch that. A very small, brief anecdotal story. I had a friend who, very, very strong athlete when we were at the UBC Tri Club, and he ate, bananas were on special. They were really cheap at the time, bought 5 pounds of bananas regularly, ate them often, heard as an endurance athlete that they're really, really important because it has potassium and obviously a lot of sugar, easy to eat, carry around, etc. He ended up having so much that the potassium slowed his heart rate, but he already had a really low resting heart rate. So the issue was the potassium slowed his heart rate enough that he would almost pass out, feel really faint and dizzy every time he would go to stand up, that sort of thing. Went to the hospital. They couldn't really figure it out till they honed in on this potassium intake thing. And again, the alarms on the pulse oximeters, or the heart rate machines, like the ECG machine beside his bed, would go off just while he was resting and feeling normal because he was just resting, but his heart rate would be so low it'd set the alarms off all the time. So the nurses would come running in, worrying about him. But at the end of the day, he was just resting and had a low resting heart rate. Okay. Average, as you again know from the lab, was about 60 to here it's saying 66 to 71, which is probably for a full adult population. And on the very high end, you know, you're looking at 80 to 100. If you're working with individuals with heart rates this high, and I just look at the first column, and unfortunately, I have to say the men's column always seems to be on the left, but obviously there's a similar correlation for women on the other side. I'm not trying to be exclusionary there. It's just hone in on the first column I see. But yeah, so again, if we're looking at 82, 84 to 104, on the high end here, if you're working with individuals with heart rates around this, you'll definitely need medical clearance before you get them exercising, and follow a very slow and low graded exercise regime. Again, trying not to get the heart rate too high, and just being mindful of that. Okay. So speaking to the linear relationship here that we're talking about between heart rate and just VO2 and power output, when you're conducting your test, so for example, like a VT1 test or your Bruce Submax or modified version, what we'll tend to find is, again, as our power increases over time, settle into our aerobic, or VT1, we'll see that there's a period and point in time where we very linearly respond in our cardiovascular output to our power that increases. Okay. We do not find this with strength training. So for example, as we start exercising and lifting heavier, so this is 50% of our 1 repetition max, so the maximum we can lift for 1 RM, to our 1 RM, we actually have a decrease in beats per minute as we get towards that. So if you're lifting and you want to work on strength endurance, definitely you want to be somewhere in the ballpark of 50 to 70% of your 1 RM when you're lifting weights in a metabolic conditioning format workout, okay? So that should be enough to get a higher rep range, but also it will help increase your heart rate while you're lifting versus doing a 1 RM lift, which will actually decrease your heart rate. And that's due to the vascular changes primarily of your body. But again, if you're looking at this end to try to increase your cardiovascular fitness, you could lift somewhere in that range and still get a response that you're looking for. Okay, so we'll shift gears and look at blood pressure now. So when you would have done this in your lab, one of the first things you did, you auscultated or listened to sounds coming from your organs, in particular your heart. So you used a sphygmomanometer. And the process was you'd inflate the cuff to cut off the blood flow of the brachial artery. And when you listened for a sound at that point in time, you would have not heard anything. Okay. Then you slowly deflated the cuff as you had that stethoscope still on the brachial artery, and slowly, as blood started to be able to get through your squished arm and that squished brachial artery, all of a sudden you could start hearing some blood flow downstream from the cuff, right? So blood was starting to get through. All of a sudden you hear that first sharp thump. That is your first Korsakoff sound. So that's your systolic blood pressure. Remember, the highest amount of blood that could push through the cuff. Once you heard that high sound, it was still fighting to get through. Because of that, you had all this turbulent blood. And you could hear the whoosh, whoosh. And that was the blood still just trying to push through, even though it wasn't fully able to flow through yet. So it's fighting to get through with that every pump, even though the cuff was deflating. Slightly higher pressure still, because it's still between your diastolic and systolic, so it's still enough pressure to kind of cause some turbulent blood flow. And then finally you hear the fifth Korsakoff sound, which is the blood pressure cuff reaches the point where your artery is able to flow laminally. So what that means is flow without any turbulence. And because it was flowing without turbulence, it wouldn't make any sound. So at that point in time, you heard nothing, blood was flowing fine, and that was the lowest blood pressure that your artery has, and that's your diastolic blood pressure. Okay. Here's a diagram. Should all be very familiar with this. So our normal blood pressure, as many of you know, would typically be somewhere around 120/80, so 120 millimeters of mercury to be specific for our systolic pressure, over 80 millimeters of mercury for diastolic. And of course, because you've all learned how to measure and listen for this perfectly, you will know it rarely lands exactly on 120/80, if at all around that ballpark, depending on who you have, even though that is a norm, it's just a starting point. From there, you'll find that your systolic blood pressure, when we're exercising, can increase all the way up again to about 200 as a systolic over your diastolic, which does not change. Now, if we pause to think about this for a moment, why might this make sense? Well, of course, as we're increasing our heart rate, we're going to increase that pressure, and systolic is going to pump harder to get blood out through the body, whereas if we're thinking about our diastolic blood pressure, it does not make any sense for that to go up. That is the lowest amount of blood pressure, and it's just during the refill of our heart. So that doesn't really change. What does change is the amount of pressure that we want to pump blood around to get to our periphery of our body. Okay. One more way that we can look to measure while we're performing cardiovascular endurance tests to see a sign of fitness is our electrocardiogram, or ECG. You might also see EKG, and that's from the German version of the same word. Typically, we use that for in a clinical setting only. You wouldn't see this very often in a health and fitness setting, and it's really for stress testing people looking for the signs and risks of cardiovascular disease, or for people with specific heart problems. Again, the waveforms on the ECGs, as we saw in the cardiovascular unit, represents the contraction, relaxation of heart chambers through the electrical nerve conduction system. We get a good indication of when that's happening. And when we look for normal or abnormal cardiac functioning, we look at the waveform for both the height and the width and the spacing of each of those, which indicates the timing of everything and the shape of the waves as well. Now, you don't need to know a lot of the abnormal cardiac functions, just that when these shapes and sizes and widths and heights change, it means different things happen to the heart. Okay. Another tool we use for cardiovascular testing is RPE, or perceived exertion measurements. RPE is one, and there's a few different scales of that. But typically it's some rating between 6 to 10. You can also use 1 to 10, but people have a better idea of exactly what is between 1 to 10. If you use 6 to 20 while they're exercising, it's hard for them to guess exactly what response you might want to hear. And therefore it can be a bit better of an indicator if you're using that scale. And sure enough, it typically corresponds fairly well to your percentage of heart rate and or oxygen uptake, or your VO2, right? So these two are typically well correlated to people rating their RPE. Now, this is more so true and even more accurate with athletes, in particular those that use heart rate often while they're training. They just have that biofeedback and a really good internal mechanism that way. Okay. So this ultimately should be obtained from the subject. It says in the last 15 seconds of each stage of a graded exercise test. And ultimately that's just to get a better idea of how they're doing and feeling. If you ask at the start, they might not have hit steady state quite yet, so they don't know, truly what they're feeling as far as their perceived effort. So usually you'll have a Borg scale, which will look like this. With some words, so they'll hone in on hard and say a number slightly more or less, or very hard, and give you numbers that way. And sure enough, we have corresponding maximum heart rates or percentages of VO2 max. We will talk about blood lactate in a later video, but you can see that we'll start hitting our 4.0 threshold here and 2.5 there. Okay. Now, let's say someone is doing their exercise, they're maxing out, and they are at a 19-20 maximal heart rate, maximum VO2 percentage, but they're still trying to push through, and you are unsure if you should stop. They look like they're in a lot of discomfort. They look like they're in a lot of pain. Here's when you should be thinking about terminating a test, regardless of what the person says or how they're performing. One is if there's chest pain, so sometimes that might indicate an MI or heart attack, or something that's less than a heart attack, which is angina. So that's a possibility, and usually the indications there is like chest pain, radiating pain into the arm, or things of that nature. That's an indication of that. There's abnormal blood pressure present. We spoke about that. So anything over 200 millimeters of mercury, you want to cease the test then. For abnormal ECG responses, typically that would be in a clinical setting. You'll need special training in order to identify that. But if anything looked really funny, like extra, like tachycardic, so extra bumps or signals that you saw on the ECG, that would indicate that. Discomfort or pain in the extremities. So sometimes what can happen is, and I've had clients like this before, where they get intermittent claudication. So what that is essentially your limbs, especially working limbs like legs or arms, depending on what you're working out, will not be getting enough blood sent to them. And so if you're not getting enough blood, they're not getting enough oxygen, and therefore you need to take note of that, stop the test, and send them to their physician. Pretty much with all of these, you need to emergency respond in the case of chest pain, or send for a follow-up referral for all of these in some way, shape, or form. But typically, with this one, there can be a number of things with their vascular system going on. Okay, dyspnea, which is difficulty of breathing. Now, that might be a funny one to say for a VO2 max test, where you're clearly going to be out of breath at some point in time. But this is if there is an abnormal expectation of excessive out of breathness. If someone is hyperventilating and they seem like they are not getting enough oxygen and they start doing that, that's a good time to end the test. And any one of these could lead to dizziness or sinuscope, which again is just another variation of dizziness. Okay, so all really great times to stop. The other most important one, not listed here, if the client or patient wants to stop, that typically is a great time to stop. Obviously, before you start, when you provide instructions, you can say they can stop at any time, but also encourage them to push through until they feel like they have done their best effort. Okay, great. So that was a review and some new ideas in and around our cardiovascular endurance tests.